Hello, and welcome to the CME CE accredited video discussion titled Overcoming the Challenges, Strategies for Managing Patients with Multiple Sclerosis. I'm Dr. Edward Fox, Clinical Assistant Professor at the University of Texas Medical Branch and moderator for this educational activity. I'm joined today by two individuals, Dr. Clyde Markowitz, here first on my left, the Director of the MS Center at the Hospital for the University of Pennsylvania. On the far side, Dr. Barry Singer, who's the Director of the MS Center for Innovations in Care at Missouri Baptist Medical Center. So welcome to you both, and thank you for joining me.
Thanks, Ed.
Thanks, Ed.
In segment 1, we discussed diagnosis and treatment of MS. We'll now shift to segment 2, titled Managing the Patient, Prioritizing a Care Plan. Our topics of conversation will be the role and synergy of a proactive multidisciplinary MS patient care team. This is a disease that requires the interaction between patients and a number of caregivers over time. An effort to strengthen the communications among the MS pair team with the patient would certainly lead to better outcomes. Improving the patient quality of life is one of those outcomes that we're going to be looking towards in this section. And then we're going to cover a case. The learning objectives then are that those people who follow this plan are going to assess the optimal treatment strategies and patient responses to treatment for improving patient outcomes, and will be able to implement effective side effect management approaches for improving patient quality of life and implementing the effective communication and patient management strategies for improving the overall patient well-being. We begin with some pre-assessment questions. The first question is as follows. Patient-reported outcomes, or PROs, have the advantage over objective clinical findings in defining which of the following. Number 1, the annualized relapse rate determination as seen in clinical trials. Number 2, the expanded disability scale score, or EDSS. Number 3, employability. Number 4, gait disorder. Or number 5, visual disturbances. Please make your selection now. Our pre-assessment question number 2 is as follows. Factors supporting a favorable response to changing to aggressive MS therapy in the presence of breakthrough activity on a first-line treatment include all of the following except number 1, early course of disease, number 2, age greater than 50, number 3, gadolinium-enhancing lesions seen on MRI of brain, number 4, ambulatory state, number 5, absence of cerebellar or spinal cord pathology, number 6, 2 or more relapses in the previous 12 months. Please make your selection now. Well, I now want to turn it over to Dr. Markowitz, who's going to begin our discussions about interactions with patients and making a care plan with those patients. So, Clyde, take it away.
Thanks, Ed. So we're going to talk today a little bit about patient-reported outcomes. And in a disease like MS, this is very important. You know, for one, when a patient comes into the office, they can tell you a little bit about some of the symptoms they've been having, such as fatigue or sexual dysfunction, but we don't have a quantitative way of assessing that in our clinical practice. So when a patient gives a history, we have to use that information to determine is this, disease affecting them in these areas. And this is really not captured in our clinical trials, but is a very important piece that we need to capture in our day-to-day practice with patients with MS. So we try and assess what we can. There are some tools that can be used as patient-reported outcomes. We can look at their quality of life, we can use their ADLs, and we can look at other things such as employment, their independence, their functional capacity, and these are all metrics that are very important to capture, but unfortunately are not captured easily in the day-to-day visits that patients come into the office. Now, there are some scales that have been shown to be valid. But, it's somewhat cumbersome and a little bit time-consuming at times to use these scales in the day-to-day practice, but I think that you'll see more of this in the future. And they provide some very, very adjunctive, useful information to the care of the MS patient. So we're going to assess their clinical response to a therapy, and that may look like the frequency of their attacks or MRI lesions, but we also need to look at these other patient-reported outcomes because they can be particularly useful to determine is this patient adequately managed. You might see a reduction in lesions or you might see reduced frequency of attacks, but you may not control their fatigue or their depression, and those pieces can be assessed as well and need to be used to determine if a therapy is adequate for a patient. And one of the challenges that we have is that in MS, symptoms of MS can be, dependent upon other symptoms, such as, fatigue can lead to depression. Depression can lead to, reduced compliance with medication, which can cause more problems with, cognitive function, or bladder problems, which then, can more get involved with their sleep dysfunction, which contributes to their fatigue. And it's just a circle of things that can just go and go. And so you kind of have to look at each of these individually, treat them as, they're all dependent upon other symptoms. And you have to kind of figure out what's contributing to what and try and address each symptom individually. So what do we typically use in our clinical day-to-day practice? We look at relapses to determine is a patient adequately managed. We look at their disability progression. Most commonly in our clinical trials, we do EDSS scores. And in some clinical practices, they can do that as well. But a lot of times, functional outcomes can be useful as well. How long are they walking? Are they able to walk the same distances that they were previously? How are they doing in their day-to-day function around the house, in their job, in their cognitive functions, these kind of things. And we also look at things such as their MRIs, looking at lesion formation, new lesions on the MRI scan, any active lesions. We try and determine brain atrophy, which may be a particularly useful one. In patients previously who've been on interferon therapy, we might do some additional testing such as NAB testing for interferon antibodies. So there are a variety of tools that we use to determine if somebody is adequately being managed. And with the advent of the JC virus antibody test with natalizumab, we'll be using that serially as well to see if people convert from negative to positive as well. So all these tools are being used at one time when we assess patients' ability to be adequately managed with therapy. There are some markers that tell us whether a patient is going to be a good responder to therapy or not. And we've learned this really looking at the natural history of MS and prognostic factors that tell us if somebody's disease is going to be more aggressive or less aggressive. But we also have some information now that kind of puts people into categories of favorable or unfavorable response to a particular therapy. And those include, like favorable response metrics might include that, they have a disease that, we've picked it up early in the course, they're younger at age, maybe their disease activity hasn't been too active, or, it's been in the recent past active, and the number of GAD-enhancing lesions on an MRI scan. These might be the kinds of patients who respond to the kinds of therapies we currently have, which we call the anti-inflammatory type medications. The patients with less likely to respond to therapies are people who might be, long-standing disease, older patients, people who have a lot of disability that's somewhat fixed and they've remained like that for many years, cerebellar symptoms or, motor symptoms that are, long-standing. The cerebellar symptoms can be very, very difficult to treat, both symptomatically and over time in terms of disease progression. Looking at atrophy on an MRI scan can also be a particularly useful indicator that this patient may not be as good a responder to a therapy, whether that be brain or spinal cord. So these kinds of things can give patients and give doctors the ability to stratify people into more or less likely to respond to a given therapy, given the current therapies we have. So there are barriers to patients adhering to therapy. So, we've talked a little bit about some of the therapies and the side effects and the concerns that people have about injections or some of the side effect issues. And these can be barriers ultimately to keeping patients from adhering to the therapy. And we've learned that over time, one of the biggest concerns for disease progression or breakthrough disease has been inadequate adherence to therapies. And so we have a huge responsibility to try and identify these patients early and make a plan to get them onto an adherence plan of some sort. But some of the things that clearly are barriers, like, if they have cognitive issues that are, they're forgetting to take their medication, or if they're depressed and they don't want to take their medication. Some physical symptoms, particularly if you're talking about doing injections, people may have tremors or weakness that would really prevent them from doing it independently. They may need a caregiver to help administer that. Some other issues, particularly if for pills, it might be a little bit easier, but again, certain patients may have enough weakness that they may not be able to hold a pill or have enough dexterity in their hand to be able to do that. We've learned that cognitive issues can be a huge issue, and patients not really understanding the disease itself and understanding the implications of the treatment can be a barrier to them adhering to the therapy, that they don't really understand MS and think that doing the medication may not be of much benefit. So it's our job to make sure we educate patients adequately about that. Clearly, emotional issues such as whether they have depression or anxiety or some unrealistic expectations can all contribute. And of course, there's some issues related to IV access for certain of the medications, particularly in patients who may be dehydrated, not adequately getting enough fluid intake, or are somewhat obese. These issues can also be a problem from an access standpoint. One thing that I think has surprised me to some degree is that, when you look at a drug that is required to be administered in the hospital on a monthly basis, or if patients coming in for a couple of days, even access into that particular location can be a problem, particularly for patients who have some mobility issues where they may have to park their car at a certain place, or to get into the hospital to get that treatment could be an issue as well. So when we look at the unmet needs in MS, particularly with regards to therapeutics, clearly from a symptom standpoint, you need to come up with, drugs that decrease the MRI activity and improve quality of life. That's a huge issue because some of the medications don't necessarily improve quality of life, even though it controls the disease activity. They may not necessarily perceive it as a control of improved quality of life. Ideally, we'd love to have therapies that halt or reverse the neuronal damage that's occurred in MS. We need drugs that promote remyelination, improve neural repair, and give people really long-lasting disability progression-free time in their life. Something that really is lacking because, these drugs work and slow the progression, but we need to halt it, and we need to give people improvement in that arena. Clearly the dosing issues, convenience, taking the medication that's going to have a very minimal side effect profile, or medications that are easy to administer and are safe, that don't cause any other concerns, and the monitoring involved with that. So these are all of the unmet needs in the MS world these days, and we really have a lot of work to do in the future. But as you can hear, some of the drugs that we've been testing over the last couple of years look very promising, and we're hopeful that some of the drugs in early phase trials at this point will address some of these unmet needs. So I'm going to turn it back over to Ed now.
Thank you, Clyde. I'm going to be turning it over now to Dr. Singer, who's going to talk to us about the oral medications, emerging medications, and basically how we're going to be looking at these new medications in order to have the proper communications with our patients about the medication choices. So, Barry?
Thanks, Ed. So I want to dive into oral medications for MS, and there's certain clear positives with oral medications, and then there's also some myths about the role of oral medications in the treatment of MS. So let's dive right in. We've been spending a lot of time, in fact, I've been involved in clinical trials for oral medications for MS for about 18 years because patients clearly prefer a tablet or pill as opposed to doing injectable medications if possible. And why is that? Well, many patients have significant injection phobia. I saw a patient this week that spent 2 to 3 hours trying to get geared up before they would give themselves an injection. In addition, the advantage of an oral medication is a lot more portable, so patients can take it with them when they travel. It's easier than traveling with injections, so it makes it a little more simple in terms of treatment administration. In addition, the injectable medications also have a visible reminder of the disease. Many patients have red spots on their arms and legs, and they have this reminder, and in fact they have to explain it frequently to other people that inquire about the injection site reactions, and occasionally you can have significant injection site necrosis. In addition, you don't need training on how to take a pill, so you get away from the injection site training that requires a nurse to come out to the home and spend some time. And that creates sometimes some anxiety in those individuals that have to do injectable medications. And it may be a little easier for delivery. You don't have to worry about if your medication needs to be refrigerated. Is it being dropped off at the house on a hot summer day? You don't have to worry about a lot of those type of issues. And clearly the medications, even oral medicines, have to be kept within a certain temperature range for them to be safe, but a little less in terms of delivery. However, I think there's some misconceptions about the oral medications, and I primarily with patients think that oral medications may be less dangerous. Well, that's not necessarily the case. In fact, with our injectable medications, interferon and glatiramer acetate, we have long-term safety data now for, we're getting up to 20 years with these type of therapies. So we know that we know about the long-term risk of these medications. And we do not have that same data necessarily with some of our newer agents, although they may be similar to other products that have been on the markets. In addition, there's also this concept that they would be less time consuming. Well, we know with certain medications, to get initiated on treatment, it does require a little more. For example, fingolimod, there's certain monitoring that needs to be done on the first dose, maybe some blood work that should be done before you initiate therapy. So there is some other steps that may be involved with an oral medication. It's not simply walking out of your doctor's office with a script for a pill. And one of the other issues that comes up is the cost of the medication and how these medications are tiered. So even if a medication is approved necessarily for first-line availability to patients, the cost of the medication is also having some influence on whether you have access to that treatment as a first-line agent or failing treatments. So that's another myth. If you get an oral, someone writes you an oral prescription, you can't just go and pick it up. You still require prior authorizations to get that medication available to you. And so and follow-up is going to be very important with many of our oral medications, close follow-up to monitor the side effects of the medication and potential risk. They actually might require more close management as opposed to less frequent evaluations. So one of the things that comes up is you're in an exam room with a patient, and we have now spent a lot of time talking about the various agents that are coming forward in the near future in terms of oral medications and those that are available now, which is fingolimod. So we spent a lot of time talking about what these options are, and in order to do that, we need to kind of go in detail about what the benefits of the medications are and the potential risk. And what's important is that you have to compare this against the benefits and risk of our current known medications. And many patients come in and they've done very, very well on their injectable medications. Their disease has been well controlled. And they say, here's a new oral option. Should I switch to it? And so the questions that we need to go through with them is how long has it been on the market? What is the safety data? What do we know about it? And help make them a decision, help with them form a decision whether we should move to that new agent or not. And that requires a patient's understanding not only the benefits of the medication, but also the risk of the medications. And so many patients, we can make that decision together. For lots of patients, it ain't broke, don't fix it. You've done well, and that mechanism of action has worked very well for you. But there are other patients not responding. We talked about breakthrough disease, having new relapses, patients that are having increased disability, having new MRI activity. Those would be great patients that may need a new agent. Some of these new agents are having superior efficacy than some of our older agents in head-to-head comparison trials. The other big group of patients is patients that are not adherent to their treatment. So they can't really stick with their medication. Frequently, you'll see patients that are having a relapse and you ask them, are you taking your medication? And they're not taking their injections on a regular basis. They've been off of medication for a month or two. And a year goes by, and say, oh, I'm going to do better. And a year goes by, and sure enough, they're having another relapse or new MRI enhancing lesions. And it turns out they're not taking their medication. So those individuals are also going to be very good candidates potentially for switch medication, potentially an oral medication. I think there's kind of some myths that if it's an oral medication, people stick with it better, but we know that some patients don't take oral medications. And with fingolimod, there's big concern. If you stop for more than 2 weeks, there's first dose observation needs to be instituted again. And some of our medications, including BG12, which is BID, adherence is going to be very important because once a day may not be effective. So that's going to be very important for patients to understand. And I think there's also going to be realistic expectations of what patients should derive from these medications. I think some people think, oh, well, I'm going to go on a pill. Well, that's going to cure my MS. I'm going to be free of disease, and they want to switch. But I think they have to understand that these medications are only going to prevent new injury over time. And that's really the goal, is to prevent new relapses over time. So what are our goals of therapy? So one of our goals is clearly to reduce new relapses. So when we pick a therapy, we want to have less exacerbations, which can be disabling for patients and disruptive to their lives. We want to find a medication that can have an impact in preventing disability. Can we keep it ambulatory over time? And then the other things that we're looking at, which is a big reason for a lot of patients going on disability, is cognitive problems or cognitive dysfunction. There's some new parameters that are being looked at in many clinical trials in terms of brain volume or brain atrophy, with some positive results with some of these agents. And then clearly quality of life is very important. If a patient is struggling with side effects of the medication, then that's not a great outcome. So you want to have patients that are feeling well and doing well on therapy. So that's one of the options with some of these new oral agents. If you're not responding to your other medications, switching to these agents can do better. However, these new medications also have potential side effects, and we hear about alopecia or nausea or vomiting or GI side effects, flushing. So there, you will have to manage some of the new side effects with the new agents. So when you have an individual patient, we have to focus on a lot in the clinic, and it's getting hard. You have a limited amount of time with an individual patient. There's a lot of assessment that needs to go on. First of all, what type of patient? Are they a clinically isolated syndrome patient? Are they a newly diagnosed patient? Are these patients that are not responding to current medication? Do patients that are non-adherent to therapy? And then you have to think about the individual patient. You look at their comorbidities. Do they have issues with depression? Do they have a history of diabetes, which might put them at increased risk for macular edema with fingolimod? Do they have liver disease, which might be an issue for a number of agents? What is their background? Have they had a history of malignancy or cancer in the past? Do they have other autoimmune diseases? So you have to look at what their background is, and I think that's going to help in focusing on specific treatments that are currently available and also in the future. One of the things that's very important for physicians is to start thinking about sustainable long-term treatment. We have individual patients that we're going to be following long time, and many patients you might follow in your practice for 30 years. And you have to think about not just your initial treatment with the medication, but what are you going to do long-term to keep people going? And what's the impact on their immune system by starting them on one agent and switching to another agent? What if they don't respond to that agent? Is it safe to add another agent? And how much time is in between? So I think we have to think about this, and our patients need to get more sophisticated and learn about this so they can help make the right decision, not necessarily go on what the next new agent is, but what would be appropriate for their disease and help with a sustainable treatment over time. And that needs to think about not only short-term benefits, but also long-term benefits and long-term risk. So it's an exciting time. I think we're going to have tremendous more options for the treatment of MS, but it's become a very important dialogue between individual patients and their physicians, and assessing what their risks are, what the risks they're willing to take, and what the risks you are willing to take to keep their disease under control. So at this point, I want to turn it back over to Ed. Thanks.
Now I'd like to go over the key takeaways. Multiple parameters can be used to determine the level of disease control in MS. So we have multiple ways of trying to determine whether a patient is clinically stable or not, but also whether their quality of life is showing an adequate outcome. The patient-reported outcomes do have a role in the interaction of the healthcare practitioners with their patients. And an open discussion of known and unknown issues regarding the new medications will be necessary for the patients to understand the decision process that goes into either remaining on an old medication or going to a new emerging medication that may be coming out in the upcoming years. And different strategies are going to be necessary for different patients. There will not be a one-size-fits-all plan that we have for these patients now, because they come in with different needs and also different risks, different background medical conditions that might impact your decision to go with one medicine versus another, and also their willingness to be able to accept potential risks of new medications. And so the understanding of the risk of disease versus the risk of treatment is going to be an important point that we're going to have on a case-by-case basis. And so what I wanted to do is talk about one particular case here in order to sort of open up the conversation that we'll have regarding our communications with these patients. The particulars of this case would be that it's a 44-year-old man that presents with transverse myelitis and an MRI of the brain revealing 2 asymptomatic T2 lesions, an MRI of the spine showing 1 lesion that is gadolinium enhancing and 1 lesion that is not gadolinium enhancing. So initiation of a first-line MS medication occurs promptly, but within 1 year he stops therapy due to side effects and is now inquiring about the newer MS medications. So a clinical decision point at this point, when the medication has been stopped and it's discussion of a new medication, is that what discussion point would assist with the decision process in changing medications? And the choices for this are, number 1, frequency of dosing, number 2, tolerability, number 3, cost, number 4, safety issues, number 5, current level of disease activity, number 6, all of the above. Please make a selection. So the answer to this question is clearly 6, all of the above. These are all important issues and things that will require, in fact, a discussion. Some things will be outside of the control, in fact, of the patient or physician. They don't get a choice as to pre-existing conditions, and they don't get a choice necessarily on the choices that are made for them about whether a medication can be used first line, second line, or so on. And so there are a number of different issues that will go into the clinical decision point about a medication change. So going on to more details about this patient, let's say this patient is very nervous about potential risks of the other MS therapies and wants to wait before starting a new medicine because they want to see what new medicines will come out in the future that might be less scary to them, but yet still be effective enough to treat the multiple sclerosis. So the question is, what can be said at this point about the choice to wait on therapies? Number 1, it is unknown when a new medication will come to market if the FDA has not yet approved it for use. Number 2, an MRI of the brain showing new activity off of medicine can accurately predict the risk of future disability. Number 3, the newer medicines will be better tolerated and safer than the current first-line therapies. Number 4, delayed treatment guarantees neurologic worsening. And number 5, newer medicines will be more affordable. Please make your selection. The answer to this question is number 1. It is unknown when new medicines will come to market if the FDA has not approved it yet. So it would be inappropriate to tell a patient that if they wait a year, they will have a certain amount of choice then that they don't have right now. We really never know when something is going to be approved, nor when it will become available on the market. The other answers to this, the MRI of the brain has not been particularly accurate in predicting disability in the future. There's some aspects of an MRI that may in fact help us, but there's certainly no guarantee of MRI activity leading to disease activity. We use it as a tool, but it is not a guarantee. The newer medicines aren't necessarily better tolerated, they're not necessarily safer, and they're not necessarily going to be more affordable as well. And some patients have successfully delayed treatment, but unfortunately for many, it does not work out well for them. And so the idea is, if at all possible, to have patients on the correct treatment for them in order to reduce the risk for accumulation of disability. So the case summary, and then I'm going to open this up for a discussion for us all, is that tolerability issues are present for first-line MS medicines. We have known this for a number of years. And many patients, unfortunately, discontinue their medicines without our knowledge. Sometimes they do let us know ahead of time, but usually not. But they still will seek MS treatment at times. The newer medicines will likely be available in the future that will increase the need for communication with patients about risks and benefits. And the continued monitoring of patients off of MS medicine is advisable to determine which patients are not faring well and might need an earlier intervention with medication rather than waiting for a new medication. So I'd like to open this up to the panel because we all deal with this quite frequently, those patients that are unwilling to take current medications and yet are potentially fearful of new medications. And it's sort of just delaying the decision process from appointment to appointment, month to month, year to year, that can often have horrendous outcomes. So how do you broach the subject with the patient? And I'll start with Barry.
Well, we look at a number of factors and what's inhibiting them. So first of all, I think they need to have an understanding of the disease. So if this individual, this man, 44-year-old man, he's got enhancing lesions, enhancing lesion in the spinal cord, a couple lesions in the spinal cord. So we know he's at increased risk for disability over time. So one of the things that's important for him to realize that late onset, a man, spinal cord disease, even though he does not have much disease in his brain, he's still at significant risk for disability progression over time. So I think it's important for him to look at his MRI scan, understand what the spinal cord is all about, and that it controls bowel, bladder, sexual function, strength, numbness, so he has an understanding of what the decisions he's making. And then it's important, I think there's a lot of misconceptions about potential risk of individual things. We're seeing press releases on agents in terms of what the risks are. And so I think it's important for you to kind of analyze that data for him. What are the safety numbers? 100,000 people, for example, have been treated with natalizumab, and if you're JC virus antibody negative, your risk of PML is very low. Fingolimod, there's almost 40,000 people treated with that to date, and these are the potential risks. So I think framing it into so that these medications, they understand the risks, but they also put it in context. So I think a lot of people have some misconceptions of what those risks are. So I think that's very important. Clearly waiting for a new agent, and we see that currently, that there's patients that are waiting for certain specific agents, and they very well may get FDA approved, but we don't know for sure. And the problem is then the period of time that you're going to be untreated. Now, if it's expected that something's coming in 1 or 2 months, then I might be holding off with an individual patient. But long-term, waiting for an agent doesn't necessarily make sense. So I think you really have to dive into what their specific individual issues are. Sometimes it's financial, and fortunately, all the medications, the companies help supply financing for patients to get those medications. So I think it's diving into those, real individual hurdles that you need to overcome to help them get on treatment if it's indicated.
Well, Clyde, I'll pose the same question to you, and just start out by saying that these patients are very difficult to see in the office because it's very time-consuming to try to go over all of these possibilities. And I'll ask what your approach is, and how are you going to deal with the increasing amount of conversation that would be necessary to cover every single one of the potential therapies for somebody who has tried one medication and could go to a myriad of different ones? Are you going to try to hone in on the therapy that you think is most appropriate, or are you going to feel like a broad discussion is going to be necessary?
Well, I think that it's a huge challenge for us because given that these newer agents, most if not all of them, have a variety of side effects and a variety of safety concerns that are different than what we're currently used to, we have to guide the patient. But I don't think that we should just kind of present all of it and let the patient choose where, they may not be armed with all the understanding of what we're talking about in terms of risks. And, you're talking about trying to educate them about every single adverse event and every issue about safety and let them come up with a decision. I think it's our job as physicians to extract all that information, make our own assessments of where we put people into various categories, and then guide patients. And of course, the patient has to be in on the conversation and the decision, but they're coming to us with our knowledge and our understanding of their disease and the drugs, and we have to be able to guide them about what we think is best for that individual patient. And a lot of times they will say to me, well, doc, I don't know what to do here. If this was your mother or your sister, what would you prescribe? That kind of thing. And I really think at this point, I think we've been somewhat lucky in that the last 10 to 15 years of therapy with interferons and glatiramer have been pretty mild in terms of concerns for safety and mostly even for tolerability for the most part. So we've been somewhat spoiled in that, we didn't have to worry so much. So patients could be more involved in that decision making to the point where we might say, well, you know what, you decide and, you let me know what you think you want to do, right? But I don't think that's going to continue that way, because now the whole world changes with a whole different array of concerns of safety and some issues with tolerability. I think that, there's a misconception out there that pills are going to be better tolerated than injections, because injections equals pain and pills equal no problem. But that isn't necessarily true, because as you know, some of these newer agents have some gastrointestinal side effects that, could be concerning, some flu-like symptoms that could be, or flushing or things like that, things that, some patients may not tolerate so well. So we have to take that information, we have to be able to have the conversations with the patient, and it can be lengthy. And so in my practice, I may go over some of the kind of general layout of what's out there, and I might arm them with specific information, but I may not be able to have that decision in one visit with the patient. I may have to have them come back after they've, kind of looked at their own world and the data and the information, and then we have more conversations about what we think is appropriate. But I think we are going to be more responsible in this next era about which therapy we're going to put a patient on. And it's going to be a conversation with the patient, but I think they're going to look more to us about what we think is the best treatment for that individual at that time.
And I imagine the risk management program, which may be unique to every product that we deal with, every medicine has a risk management program, to institute that is going to be a challenge as well. And do you both see ways that practice styles are going to have to change in order to implement this, as a team approach? For the MS practitioner?
Yeah, I think it's very important, as an investigator in some of the clinical trials, we had our systems in place. But if you're out there and you're in private practice and you're trying to start these new agents, you have to get your plan in place. You have to know, for example, with fingolimod, your system of how you're going to do your first dose monitoring, what kind of baseline, who you're going to use for your eye exams. And once you get your systems in place, the reward can be great for those individuals going on that are tolerating the agent and they're sticking with it, and you see some long-term success over time. So it's about getting your systems in place so that these medications can be an option. And I think we'll say the same thing with the new oral medications that may be coming in the near future. There may be some tolerability issues or safety issues down the line in terms of blood monitoring and how you're going to manage side effects of the medication. But if you have your plan in place, that your staff is educated, that if you have a nurse that are educated, that your medical assistants are educated, that way you can be able to handle what comes forward, and you have a systematic way of assessing blood work if that needs to be done, so that you maximize patient safety, but you also maximize choice to these individuals, that they're not, that you don't shy away from these new agents, that you have them for those patients that need a new option.
All right. Any additional comments that you have, Claude?
Well, I think that, a lot of patients come in these days and they ask, when is that oral drug going to be available? And, we have one oral drug, but they have, somewhat of a concern about some of the safety pieces to that. So they're saying, well, what about the new generation or the next oral drugs? When are those going to become available? And some of these patients are really mostly concerned about that they just don't want to do injections anymore, even though their disease is quiet and they have been controlled extremely well. And so, I think we have to kind of encourage them to stick with that plan, because there's nothing that guarantees that switching them from a effective therapy that they're doing, maybe they're annoyed by it, but they're doing it and staying with it, and switching them to an alternative oral agent, and now we don't know that their disease activity will be controlled as well as it has been on that particular drug for that individual patient. So I have to convince that patient that maybe it's better to stick with what you've got, because this drug is controlling your disease, even though it's annoying to be doing the injections or whatever you have to deal with, as opposed to switching them. So that's a challenge right now, because they really want to, something easier, even though, it may not necessarily control it. We don't know.
And the other thing is, at what point? What point do they pull the trigger? So some of these patients say, well, a drug's just come out, I don't want to jump on it, 2 years out, 3 years out. I mean, how do things evolve as we go 4 years out from now, and you start to have some more safety track record for these agents? You know, I think it would be expected that over time more patients are going to be moving on to oral therapy. But again, there's many patients that have done extremely well on injectables long term, and you know, and they've done well, and we both agree that, and they tolerate well, that they should not switch.
Barry and Clyde, thank you very much for a very interesting conversation about an unfortunately common scenario for us. We now move to the post-assessment questions that you've heard before. First one is as follows. Patient-reported outcomes, or PROs, have the advantage over objective clinical findings in defining which of the following? Please make your response now. The answer to this question is 3, employability. Patient-reported outcomes have been very effective in determining the ability of a patient to remain in their current level of employment, and in fact their ability to take on new jobs, learn new information, or be able to perform the tasks, whether it be physical or cognitive, that would be necessary for a job. The other answers are ones that are typically used either in clinical research design or in our office, but are more objective in nature, that are based on the interaction through physical examination or through the use of technology in order to be able to determine whether a patient is under a good clinical control or not, as opposed to the more subjective patient-reported outcomes, which have a lot to do with the determination of whether a patient is having changes in their quality of life. The post-assessment question 2 was as follows. The factors supporting a favorable response to changing to aggressive MS therapy in the presence of breakthrough activity on a first-line treatment include all of the following except. So please look at the potential answers and make your selection now. The answer to this question is number 2, age greater than 50. Prognosis is not as good for patients who are having worsening over the age of 50, likely because of the involvement of secondary progressive MS and the chronic development of symptoms that are independent of the development of clinically defined relapses. However, the early course of disease, the presence of gadolinium-enhancing lesions on an MRI, the ability to still ambulate independently, the absence of cerebellar or spinal cord pathology, and having more active diseases defined by 2 or more relapses over the past year would be signs of a greater likelihood of having a clinical benefit by changing to a more aggressive therapy. So this concludes the second segment of this activity. I'd like to thank my colleagues that joined me here today, Dr. Clyde Markowitz and Dr. Barry Singer. Thank you.